Welcome to our presentation on Knowledge Translation Strategies, Implementation of Outcome Measurement into Clinical Practice. I am Jennifer Moore. The individuals who have contributed to this module include myself, Carolyn Baum, Kirsten Potter, and Jennifer Pyatt. Knowledge translation is a multi-dimensional, active process of ensuring that new knowledge gained through the course of research improves the lives of people with disabilities and furthers their participation in society. Importantly, it includes the dissemination of research information and its actual use in practice. The National Institute of Disability and Rehabilitation Research is the funder for this project. NIDR has adopted the principle and practice of knowledge translation to guide its activities. They've also indicated that it is important to ensure that valid and reliable outcome measures are adopted and used by their intended users. Outcome measures should serve as the foundation of evidence-based knowledge, and they are crucial for demonstrating intervention effectiveness. NIDR has also recommended several reliability and validity considerations when adoption and use of an outcome measure and a goal. Consider whether this measure addresses well-identified needs and in what contexts. Is the instrument user-friendly? How does the instrument fit with workflow and other constraints in practice? Can practitioners use it appropriately and successfully without assistance from the developer? What incentives for the practitioner, practice, organization, and other stakeholders exist to adopt the use of this measure? What is the advantage of a new measure over an earlier measure? Is the measure acceptable to those whom it will be used? Would the measure generate meaningful results from practitioners, clients, and others? Can it be made available free or at low costs? Is there a strong relationship between the outcome measure results and real-world performance that it was meant to represent and predict? And finally, does it take into consideration multicultural contexts into everyday practice? This presentation will provide a framework to implement routine outcome measures into clinical practice, provide examples of actual teaching strategies, and demonstrate a case study of successful implementation of the measurements into clinical practice. On this slide is the Knowledge to Action framework. It is a conceptual framework that was developed by Ian Grams and colleagues. It is an approach that builds on commonalities found in an assessment of more than 30 planned action theories which focus on creating change within healthcare organizations. Canada's Federal Health Research Funding Agency has adopted this cycle as the accepted model for promoting the application of research and as a framework for the knowledge translation process. I personally like this framework because I feel that it is feasible for a clinician or group of clinicians to utilize successfully to integrate research evidence into clinical practice. For the purposes of this presentation, we will be discussing this information in the context of implementation of outcome measurements in clinical practice. In this series of slides, I will provide you with details about each phase of the cycle and examples of strategies that could be utilized in each phase. Finally, a case study of application of this information will be provided. The Knowledge to Action framework utilizes two major components. The first is the knowledge creation circle, and the second is the action cycle that is on the outside of the circle here. At the center of the circle is the knowledge creation funnel. It includes the development of primary research articles, synthesis of all the studies, and knowledge translation tools. Knowledge translation tools present research evidence in a user-friendly, implementable format that could be further tailored by clinicians who use them. In this presentation, we will briefly describe knowledge translation tools such as the Rehabilitation Measures database that could assist with the implementation of routine outcome measurements in clinical practice. Now, the action cycle, again, the part of the cycle that's outside of the circle, is the process by which knowledge is implemented. The action cycle is dynamic and iterative, and each phase informs the others. Now, we're going to start by talking about the first step in the action cycle, and this step is identifying the problem or the knowledge gap. In this case, the gap would be related to measurement practices at your clinic. Perhaps clinicians aren't using standardized assessments, or they are all using different assessments, or possibly they are not using them in a methodical way. There are various ways that the problem could be identified. It could be done in a relatively simple way by holding a meeting with your staff or conducting a survey. Observe what clinicians are actually doing in practice or provide a more in-depth approach of doing a chart audit. The information gleaned from these activities could assist in structuring education, creating tools for clinicians, and inform you in how you could overcome potential barriers prior to implementation of these activities. When performing interviews and surveys, it is important to involve all stakeholders, including hospital administrators, clinical supervisors, clinicians, and even patients. Ask questions that include assessing perceptions of utilizing measures in clinical setting, facilitators and barriers within the clinic, and within the organization. The reference article, Swinkles et al., assessed barriers and facilitators of perceptions of using instruments, and the authors included all the questions that were utilized in the focus groups and surveys. This article and others include some example questions that could be asked to provide some insight into how to develop a successful implementation project. Another way of identifying the problem is by observing what is actually being done within your clinic. Prior to observing measurement practices, create a list of exactly what you want to investigate. Here is an example checklist, including how the information that is collected is utilized for clinical decision-making, how frequently the measurements are performed, and how measurement is included in patient education. A chart audit could also be performed to identify current measurement practices. Many clinics already perform chart audits for quality improvement. In this case, you would just need to add some components related to measurement. This slide includes some relevant questions that could inform how to educate the standardized administration of measurements at your site. The Duke website at the bottom of the page is also a great resource that includes a great how to do a chart audit and actual chart audit samples. When thinking about a chart audit, there are some areas that you might want to define, including selecting a representative sample, including patients that are typically seen or perhaps represent the area of practice that you hope to implement outcome measures within, such as stroke patients undergoing gait training. You should also define which levels of care should be included and the specific number of charts that should be reviewed. The Duke website provides a recommendation of 10% of available charts for a given time period. Other areas of measurement you may want to investigate are whether documentation includes how the results of the measurement inform clinical decision-making, whether the measurement was taken in routine intervals, and whether the measurements are appropriately utilized in goal writing. It is also important to provide clinicians with feedback from the chart audit. Many times this step is not taken. However, the results of the chart audit could be a very powerful way of educating about the components of documentation that are strong or may be missing. The next step in the action cycle is adapting the evidence to a local context, which promotes appropriate application of the evidence within your specific clinic's needs. When adapting knowledge to the local context, it is important to protect the evidence and its recommendations, but package the information in a way that facilitates its use. In doing this, it is important to include all stakeholders, most importantly the clinicians who will be using this information. Look specifically for instruments that have been tested in a population of patients that are similar to the patients that you see. When the information is reviewed, discuss the barriers and facilitators of applying the information at your clinic and include them on the document. Include information such as documentation, where should the information be documented, how often should the tool be administered, how to bill for the administration of the instruments, and where the equipment is located, who the experts are within your system of care, and so forth. Anything that would assist the clinicians in administering the instruments should be included on the document. This is an example of how an existing knowledge translation tool that is freely available in the Rehabilitation Measures database could be adapted to your clinical needs. This is a document that can be pulled off of the Rehabilitation Measures database that describes the psychometric properties and clinical utility of an instrument. This summary could be adapted to include the information that refers to a population of patients that you see in the clinic and their associated reliability, validity, and indices of change. You could also include specific considerations for your system of care, such as which levels of care it should be administered, when to administer them, and where to document the information. Site-specific information could also be added, including where the equipment is kept, specific testing areas, how the information can appropriately be utilized in goal writing and documentation. The next step is assessing barriers and facilitators to knowledge use. Assessing the barriers and facilitators at the clinical and organizational level has already been described to some degree in this presentation. However, it is important to look at the specific instruments you have chosen and reassess barriers and facilitators. As previously mentioned, that information about how to overcome these barriers can be included on the knowledge translation tools and in the education provided around the instruments. Some barriers that have been identified in the literature include the time it takes to search for a new instrument and learn how to utilize it, knowledge, available equipment, and possibly even individuals such as opinion leaders who may be resistant to change. From an organizational standpoint, barriers include time and cost and multiple cultures. Facilitators could also be held within an individual, including having a positive attitude to measurement and change and the value it adds to practice. Many external resources, such as access to concisely summarized research, which we will discuss later in this presentation, can provide ways to overcome various barriers. In knowledge translation, selecting an intervention refers to the actual strategy that will be used to educate the staff and implement the instrument into clinical practice. The intervention should be tailored to overcome the identified barriers to increase its success. Two strategies that may be successful are educational outreach visits and knowledge brokering. It is also extremely important to select interventions that will assist in overcoming common barriers and also include how performing routine measurements is valuable to clinicians, that it assists in clinical decision-making and can facilitate optimal improvements in patient function. Prior to defining the intervention, it is important to identify objectives of implementation of the standardized measure. This will also include a metric to which success can be measured against. This slide includes some examples of objectives such as standardized care, improved communication between levels of care. Some examples of how the selected strategies will assist in overcoming barriers include providing specific boxes with equipment and identified space in the clinic to perform the measure, and altering documentation to help remind clinicians of which instruments they should use and when they should use them. Other solutions to clinical barriers include documentation, equipment, and thinking about the time it takes to administer the instrument. From a documentation perspective, it could be helpful to keep test packets of all routine tests somewhere in the clinic. And then also make sure that there's an easy way to record the results of the test. If you're using paper documentation, create a testing form that includes all tests performed regularly. If your clinic uses electronic documentation, designate a specific place to record the test results in the record. It is also helpful to create cheat sheets with meaningful change scores. When thinking about the equipment that you use to administer the test, it is helpful to designate specific areas for testing. You could easily change the tile color if there are certain distances that need to be measured on the floor, and designate markers to indicate specific distances whenever necessary. Also create testing kits for common instruments and a specific place to locate them. When thinking about time to administer the instrument, it is helpful to create checklists for each patient to ensure all measures are taken throughout the episode of care. Also determine when an assessment could be included during a treatment session. One knowledge translation strategy that is supported by the research is an educational outreach visit. This type of knowledge translation intervention has demonstrated success in the literature. This strategy uses a content expert that provides education that is tailored to address your specific needs. An example of this would be inviting an expert in gait measurements to provide a course on administration of these instruments in clinical practice. Prior to the course, the expert would survey physical therapists to determine barriers, tailor education and intervention strategies to address the barriers. And the education is typically provided by a respected person. In a Cochrane review published in 2007, there was a median 5.6 improvement in compliance among all studies. Another intervention is called knowledge brokering. A knowledge broker is a popular knowledge translation and exchange strategy emerging in Canada to promote interaction between researchers and end users, such as clinicians, as well as to develop capacity for evidence-informed decision-making. A knowledge broker provides a link between research producers and end users by developing a mutual understanding of goals and cultures, collaborates with end users to identify issues and problems for which solutions are required, and facilitates the identification, access, assessment, interpretation, and translation of research evidence into policy and practice. Knowledge brokering can be carried out by individuals, groups, and/or organizations, as well as entire countries. In each case, the knowledge broker is linked with a group of end users and focuses on promoting the integration of the best available evidence into policy and practice-related decisions. If you work in a large system of care, you could potentially use knowledge brokering intermediaries that are located at each site of care. This could provide a local champion to help with implementation across a large system. There is a bit of evidence to support knowledge brokering. In one study, it was evident that knowledge brokers stimulated a peer-to-peer learning culture. In another one, knowledge brokering activities included self-learning, teaching, presentations to large or small groups and individual PTs, preparation of resource binders, educational materials, etc., liaison with stakeholders, and networking with other brokers. In a separate study, the authors found that knowledge brokering significantly increased the use of pediatric measurement tools in clinical practice. The next step in the Knowledge to Action framework is monitor knowledge use. When you're monitoring the use of knowledge in the clinic, it's important to consider changes in knowledge levels, understanding, or attitudes. Look for increased interest in outcome measures or an improved understanding of the evidence, application of the instruments, and interpretation of the results. Also look to see if there's been a change in attitude to ensure that therapists are thinking more positively towards utilization of outcome measures in practice. Also look for actual changes in behavior or practice, such as the actual utilization of standardized measures. Also, look to see whether the clinicians are integrating results into decision-making and the plan of care. To do this, you could just redo the same surveys, interviews, and chart audits that you did at the beginning of this process to identify the problem. The next step in the Knowledge to Action framework is evaluate outcomes. It's important to evaluate outcomes at various levels, including the patient level, the clinician level, and the organizational or process level. At the patient level, look to see if the patient's improved in functional outcome, whether the length of stay is changed in any way, and whether the patient is more satisfied with his or her care. At a clinician level, look to see whether the patient is changing their decision-making as a result of utilization of measures in practice. Are they more efficient with their care and more satisfied with the care that they are delivering? From an organizational standpoint, look to see whether the overall patient outcomes of the entire hospital system are improving. And how is this impacting reimbursement? Are you getting reimbursed more, less, or the same? In order to understand these outcomes, you can continue to utilize surveys, questionnaires, chart audits, and other data such as FEM data to understand the impact of your project. The final step in the Knowledge to Action cycle is to sustain knowledge use. At a clinician level, it's very important to continue to make measurement relevant, and you can do this in many ways, and we've included a few of these ways on this slide. Try to continue the staff education on measurement. Develop ongoing journal clubs to discuss measurement topics. Include annual competencies and standardization of instruments that your clinicians are using regularly. Ask your clinicians to routinely report test scores and conference on notes and so forth. Provide a place in the documentation for the clinicians to provide the patient's results of their outcome measures. And then also integrate communication about test results between clinicians as they are handing off patients from one staff member to another. From an administrator perspective, there are many things that can be done to support the sustainability of your project. Supporting ongoing outcome measurement champions can be very helpful. This can help to identify an individual accountable for continuing to update the practice at a site of care. Also include financial support, such as including outcome measurement utilization as a part of merit increases for the clinicians. allow some protected time for learning new measures whenever possible, and send staff to continuing education courses related to measurement whenever possible. To help synthesize the information on the Knowledge to Action framework, I'm going to present to you a case of successful knowledge translation in a large system of care. Now, the case that we're going to talk about occurred at the Rehabilitation Institute of Chicago, which I will refer to as RAC. RAC has 192 inpatient rehabilitation beds, 30 additional day rehabilitation and outpatient sites, and 3,000 inpatients and 17,000 outpatients are served annually. Our allied health staffing includes 134 physical therapists, 81 occupational therapists, and 43 speech-language pathologists. As we discuss this case, I will work in the steps of the Knowledge to Action cycle. So before I start with this slide, I would like to spend a minute orienting you to the information included within it. The bottom tabs have the action cycle listed. Each of the slides will take you through the action cycle and steps we took to implement our project. The first step in the cycle is to identify the problem. Prior to initiating our project, we did a staff survey and a research project to determine our current implementation of evidence-based practices throughout our system of care. In a staff survey, 50% of our staff reported they had difficulty determining the impact of their interventions on patient outcomes, and 50% of the staff indicated that they didn't understand the evidence that existed for the assessments they use in clinical practice. In a separate study, we conducted a chart review and found that only 10% of patients with stroke were measured using standardized assessments in clinical practice. In comparison with the literature around utilization of standardized assessments and evidence-based interventions, we concluded that our practice was consistent with research reports indicating that there is lack of utilization of evidence in clinical practice. Our work to identify the problem also helped us to understand the reported barriers to evidence-based practice. These included access to the literature, training to critique the literature, having the time to read and analyze the literature, and the time to seek evidence for each patient treated. Since our clinicians reported barriers included access, time, and understanding, we felt it was very important to adapt the wealth of evidence available to meet the needs of our clinicians. Our innovation is called the Battery of Rehabilitation Assessments and Interventions, or the BRAIN Project. We developed a database that contains several concise 1 to 2 page summaries that describe the evidence that supports assessments and interventions in a way in which it could be easily accessed, read, and implemented at the point of care. The assessments included the instruments psychometrics and clinical utility, barriers and facilitators to utilization, tips for using the measure to guide goal writing and documentation. In addition, a clinical bottom line section was developed that provided the quick and dirty version of the summary, including whether the instrument was recommended for RAC's clinical practice. The intervention summaries include a concise summary of parameters and dosages of the interventions that were used in research studies. Additionally, a brief description of what is expected to change as a result of the intervention based on the research was included. These were linked to specific outcome measures that would likely be able to capture improvements as the result of the intervention. For example, intensive gait training in the research resulted in improved gait speed. Therefore, a 10-meter walk test was recommended to measure changes that would result from gait training interventions. The strength of the evidence that supports the intervention is described with a brief overview of results and the studies. Additionally, tips to improve documentation of the intervention in the medical records are also included. Both assessments and intervention summaries include patient populations similar to those seen at RIC. In order to develop this resource, we recruited staff physical therapists, occupational therapists, and speech therapists, research clinicians, and managers to review and summarize the literature. We called these individuals our brain specialists. Since many of our clinicians reported they didn't have the knowledge to critique the literature, each year we provide several foundational courses to the specialists on how to read and critique literature, understand statistics, and appropriately utilize measurement. Additionally, each brain specialist is assigned to a mentor who will assist them in reading and understanding the literature and creating brain summaries. We also utilized an advisory board of physicians, researchers, administrators, and new graduate and experienced clinicians to provide input about summaries, format procedures, and our dissemination plan. The advisory board initially met to guide the development of the brain, and we plan to meet again in the next year as we plan to expand the project. Here's an example of a brain outcome measurement summary. It's very similar to what you would see on the Rehabilitation Measures database, but we have also included some very specific RIC information about when the test should be administered, our standard administration of the test, and so forth. Here's an example of an intervention summary. These intervention summaries also have some RIC specific information about how we plan to utilize the protocol in practice, in addition to how researchers have utilized the intervention in research projects as well. Once we developed our first 20 brain summaries, we piloted the project with a group of inpatient and day rehabilitation clinicians. We did this prior to rolling the project out throughout our system of care. We asked half of the clinicians to search for answers to clinical questions using traditional methods such as the web, textbooks, and any resources available to them, and the other half used the brain. It's also important to note that this was the first time the clinicians ever used the brain. On average, it took the clinicians 3 minutes to find an answer using the brain, whereas it took more than 15 minutes to find the answer using traditional methods. 100% of clinicians who used the brain were able to find the answer, whereas only 40% of clinicians were able to find the answer using their traditional methods. Further, clinicians using the brain were able to find answers with 100% accuracy in comparison to 20% accuracy with traditional methods. After the pilot, we conducted a survey with our pilot sites asking them about their perceptions of the brain. It seemed to be overwhelmingly positive. 100% of clinicians reported they felt the brain would result in improved access to evidence, their ability to interpret the evidence. 89% of them felt the brain would require less time to read, understand, and apply the evidence to practice. Overall, our pilot provided us with information indicating the brain would help overcome the stated barriers to clinical practice. Using the brain, the clinicians would have access to the information, their knowledge of understanding the research would no longer be a major barrier, and it would take less time to access the information. Now, moving to the next step of the action cycle, we assess the barriers and facilitators to successfully implementing this project throughout our system of care. Our initial survey indicated that 90% of our clinicians valued evidence-based practice, and almost 75% of clinicians reported they wanted professional development opportunities in the area of evidence-based practice. From a social perspective, our organizational leadership had recently changed. Our organization had a vision and mission to closely link evidence to clinical practice. Additionally, we needed to develop role models in evidence-based practice and felt the brain could potentially develop these individuals for our organization. From an organizational perspective, we have many researchers with labs within our hospital and close relationships with many universities. So we felt that we would have the research mentors that could potentially need to support this project. Additionally, all stakeholders were involved in the project in some way, either through the advisory board or as a brain specialist. Looking at the economic and political side, REC has a clinical ladder program which provides bonuses to clinical staff for participating in projects such as the brain. So by working with the clinical ladder program, we were able to incentivize the participation in the project. From a patient perspective, patients expect to get the best care at REC. They come to us with very high expectations, so providing them with an explanation of the evidence to support our clinical practice could help us implement this program successfully. Now moving on to the barriers. As I mentioned before, REC is a very large system of care with 192 beds and 30 additional outpatient day rehab sites throughout our system of care. Additionally, our initial research to identify the problem indicated that our current practice is quite limited in its application of research evidence. Each of our many sites has its own culture and its opinion leaders. This barrier indicated that we may not be able to use a one-size-fits-all approach. Our intervention would need to be tailored in some way to each individual site of care. Additionally, there were many fears associated with evidence-based practice. There were concerns voiced by many leaders within the organization about how we would charge insurance for care, how it would be documented to ensure reimbursement, and how these changes would impact our ability to be paid for the services we provide. There were also concerns that a quick change in our practice might somehow alert our patients, so we needed to ensure they were educated as to why the new practice was implemented. Given our assessment of our facilitators and barriers, we decided to use a champion model to disseminate selected pieces of information from the brain. To review the role of the brain specialists, they review the literature, create brain summaries, and meet on a regular basis to discuss which practices should be a routine part of clinical practice at RAC. All summaries are stored within the brain so clinicians can access them, but only the selected topics are taught to the brain champions. We have one brain champion per discipline at each site of care. The brain champions are taught the routine practices, and they are responsible for assessing their site-specific barriers and teaching the staff at their site about the assessment or intervention. They become the on-site mentor for the evidence-based practices, and we're also the brain specialists linked to understanding site-specific problems with implementation. The brain champions are provided with regular mentoring in the topic and are held accountable for implementation of the assessment or intervention through our professional development program. We provide regular support to our brain champions. They receive education and mentoring on topics such as psychometrics, clinical utility, standardization, and we also share tips for overcoming common barriers that come up at clinical sites. Some examples are listed here. A few of the most popular included purchasing a measuring wheel for the 6-minute walk test and adding different color lines on the floor to note the distance for the 10-meter walk test. For the next step of the action cycle, monitoring knowledge use, we recently did a survey to see how clinicians are using the information in clinical practice. From the clinician's perspective, approximately 77% indicated that they have increased outcome measurement utilization as a direct result of the brain. Additionally, 54% have increased their utilization of evidence-based interventions. 58% of clinicians report they use the brain to educate other clinicians at their site, and 54% indicated they use the brain to educate patients. We are currently developing a protocol for a chart audit to determine differences in utilization of evidence-based practices pre- and post-brain. Unfortunately, we do not have the results available at this point to share from this audit. Interestingly, clinicians have really grabbed onto measurement. They have found that it really adds a lot of value to their practice, and there are actually reports of overutilization of measurement. Clinicians are administering multiple measures, some of which are redundant. There are also reports of using the items in some of the measures to practice in group treatment. Given the misunderstanding that has developed around measurement, recent brain champion services have focused around principles of measurement and standardizing a required instrument battery. To evaluate the outcomes of the program, we conducted a survey to understand clinicians' perspectives of the brain. Because of the brain, 72% of them indicated they have more discussions about evidence-based practice with colleagues. 65% of them indicated they have a better understanding of how to translate research to practice. 53% have a better understanding of research, and 42% have a better understanding of statistics. We are using our chart audits to determine actual compliance, however, these are not yet complete. From a professional development perspective, our brain specialists have developed over 150 evidence-based summaries and have another 30 scheduled for the remainder of this year. There has been a substantial organizational impact of the brain. A large number of staff are directly involved in the project, with 58 to 70 specialists reviewing literature every year, 47 to 52 champions, and 20 advisory board members. The brain has increased the interaction between clinicians and researchers, and both groups have learned more about the other's perspectives. Generally, there has been a cultural shift towards more scientific thinking, with discussions about standardized measures and change in score results and patient conferences, and questions about appropriate doses for interventions in clinical practice. Clinicians have realized some of the previously routine practices are not as supported in clinical practice through this project and have voluntarily changed the way they deliver therapy to make it consistent with the research. To date, we have implemented 19 outcome measures and 5 interventions into routine practice. To increase the sustainability of the projects we have implemented, we have chosen a multifaceted approach towards sustainability. We have added education on the brain and standardized practices to new hire orientation. We have also made changes to our documentation based on requests from the champions to make it easier to document the assessment and interventions in the patient's medical record. We have tried to streamline the utilization of outcome measures since there were many reports of overutilization. We did this by providing a required measurement battery based on the construct of interest. Clinicians are welcome to take additional instruments if warranted, but they are required to utilize the specific battery first. We have also piloted the reporting of results in team conference on a regular basis. We have provided clinicians with financial incentives as evidence-based practice is now a component of merit increases. The cost of the brain specialists and champions have been assumed through our clinical ladder program, which is our professional development program. Additionally, as the project grew, we designated specific mentors for each brain group. These are expert clinicians or research clinicians who spend time mentoring and organizing the brain. Our organization has assumed the cost of the brain leaders, which has been a very small percentage of each individual's salary. There are other plans that we're currently integrating into practice, and these are restandardization of selected topics to ensure that our staff continues to administer specific measures in the same way. We're regularly scheduling all staff and services on updates to standardized assessments and interventions. We're encouraging staff involvement in clinically based research, and we're doing regular chart audits with feedback. Now, for the lessons learned, we know that a good champion is absolutely critical to the success of this framework, and we've been working to define practice style traits and characteristics of a good champion, and we're trying to increase the accountability of the role. We also learned that we really do need to focus on a limited number of topics to implement per year to build expertise of the champions. Initially, we were trying to roll out too much information at one time, and it really limited the effectiveness. So at this point, we really tried to implement 1 to 2 topics at most per year. The key components of this project included a strong vision of REC leadership to really merge research evidence and clinical practice. Now, we involved all stakeholders into some aspect of this project. There are many interactions between multiple people of different backgrounds, and our leadership has given us ongoing financial support. On an individual basis, the brain was developed by clinicians and researchers for clinicians, and so our clinicians found value in it, they're vested in it, and they continually provide input. It's provided us an opportunity to develop and recognize our clinician experts. And the fact that we piloted and refined the project before system-wide rollout enabled us to really understand its potential and refine it to meet our clinicians' needs. I just presented on a case study that involved knowledge translation in a large system of care. Now, if you work in an individual clinic, the same steps would actually apply. Talk with the PTs and the other stakeholders within your facility. Try to understand the perceptions of utilization of outcome measures and the barriers and facilitators to their use. And brainstorm with the stakeholders about ways to overcome common barriers. You can utilize online resources to determine the best instruments based on your patient population, your clinic's needs, clinical utility, and psychometrics. And then also create tailored resources, such as abbreviated forms of the most important information, tips for clinical application, suggestions to overcome common barriers such as equipment to buy, ways to set up the environment, and so forth, and find ways to integrate measurement into clinical decision-making and goal writing. Once the measures are chosen, assess the barriers and facilitators to routine clinical application at your site and at an organizational level. Standardize the administration of the instrument, educate on the psychometrics and how to use them in practice, and ensure clinicians have access to testing and equipment. Monitor and measure success and determine how to sustain the program. Now, if you're working by yourself as an individual clinician, not within an organization, really work to adapt the information to be specific to your practice, assess barriers, develop a plan for yourself, and try. Understand that you have a lot of resources out there for support, including the neurology section, the Rehabilitation Measures Facebook page, colleagues at other facilities, and so forth. Attend journal clubs and meetings to increase the awareness and the importance of outcome measures, and store information in your clinic to support your practice. Thank you for your time and your attention throughout this module. Please contact us with any questions or concerns that you may have. Thank you.